So welcome everybody to our web seminar on what it's like working in a multi-specialty provider, MCP. And we've got a fantastic panel of people who are right at the heart of making this new care model happen. So just a little bit about some of the people behind the scenes before we start. My name's Helen Bevan, and I work as part of the Horizons group within NHS England, and I am the facilitator. My colleagues Dominic and Charlotte will be overseeing the chat room, and we'll come back to that later. And my colleagues Ollie and Catherine will be looking at what we're doing with Twitter. And what we hope is that many of you will tweet using the hashtag FutureNHS. And finally, our colleague Paul Woodley is overseeing all the technical aspects of the web seminar. So today is the first time that we've used this kind of WebEx with the new care models team and program, and the whole hour is designed to be highly interactive. So firstly, we want to encourage you to use the chat box, and Paul will be just coming on the line in a moment to show us how to do this. We want to encourage you to tweet using the hashtag FutureNHS. Also, we hope that some of you will be able to speak live, and we'll show you how to put your virtual hand up. And what we will do after the WebEx is that we will produce a summary of the content. We will also make available a recording, and we'll put these on the website and we will tweet them. And what we often find with WebExes like this is that far more people will connect after the event than during it. So I'm just going to hand over now to Paul, because I just want him to take us through some of the opportunities that we've got, to interact using this WebEx system. So, Paul, you're now the presenter.
Thank you, Helen, and good afternoon and welcome to everybody. For those of you who haven't used WebEx before, there's a couple of opportunities for you to get engaged and participate in this live session. The first, which many of you have found already, is through the chat box, which if you haven't opened it up yet, will be in the panel on the right-hand side of your screen, and you should have the ability to talk to each other as well as ask the panel questions. If you'd rather ask a question directly to one of the panelists, there's an option in the participants panel in the top right again, an option to raise your hand. If you raise your hand, when we get to an appropriate point, I will be able to unmute you. There is a third feature which we'll be using on a couple of the slides, which is the ability for you to annotate a slide. So we'll be putting up a slide shortly, which lets you describe how you are feeling and your level of knowledge with certain questions that we will be asking. Yeah.
So Paul, why don't we put that slide up and let's get a sense of who's with us today. So what we want you to do, we want everybody who's taking part to let us know who they are. And there's 6 possibilities, and you have to just pick one. So the first box is, and we're gonna let you have a pen, and we're gonna ask you to put your dot in the box that you're in. So the first one is people who are actually part of a multi-specialty community provider MCP Vanguard team. So if you're working as part of an MCP Vanguard team, put your dot in that box. The second box along is if you're working as part of another kind of Vanguard, new care homes, elective care, and so on. Box number 3 is if you're somebody who's considering potentially developing a new care model. And box number 4 is if you're somebody who's playing a leadership role in a sustainability and transformation plan. Box number 5 is I'm interested in learning about MCPs from the perspective of being a patient, service user or family member. And the last box is I'm interested to learn more and I work in the health and care system. So Paul, lots of people have worked this out already, but do you want to just show people how to do this?
Yep, for anybody who's not seen the controls yet, if you look at just above where the slide is in the top left of the screen, you should see some controls now, one of which is a pen item. If you click on that, I've drawn an arrow, basic arrow, roughly to where the pen is. So if you click on that, you should be able to mark in whereabouts you currently sit. That's it, Helen. I can see there's a lot more people getting engaged now.
Yeah. Okay, so what we can see here is lots of people who are interested because they work in the health and care system, and a number of people who are working as part of an MCP Vanguard team. We don't seem to have any other Vanguards, and we've got a few people who are patient services or family members, which is fantastic. Great. So, Paul, can I have presenters' rights back, and I'll take things from here. And also, can we turn off the pens?
There you go, Helen.
Thank you. So, so I said earlier on that the way that we wanted to work this WebEx was different to the ways that we normally do things. And so what the people taking part, many of the panelists did, was to take part in a video which we recorded beforehand. So the idea was hopefully people could watch the video so that we could have a different kind of WebEx conversation today. So that instead of sitting and listening passively to a load of people, we could actually make it much more conversational, where we can have discussion and people can ask questions, and it can feel much more interactive, because I just think that is a much better learning experience. So what I want to do now, before we get going, is I'm gonna hand over to Paul, and he is going to give us a poll. And on this poll, there's going to be a scale to 1 to 10. How much do you feel that you know about what MCPs do? So if you don't know very much, be a 1. If you're one of our panelists taking part today, you'll be a 9 or a 10, or I hope you will. So I'm now going to hand over to Paul, who's going to run the poll.
Okay, and hello everybody again. What I'm going to do now is just open a poll on the right-hand side of the screen, and as Helen explained, the question is, how much do you feel you know about what MCPs do? The scale is 1 to 10, 1 being the lowest, 10 being the highest. So I've now opened that session, so you should see these buttons on the right. I can see some people have started to click on them.
Just to say as well that we're going to run the poll again at the end, and hopefully the scores will have moved.
Okay, we've got about 3/4 of the group who've answered so far.
We'll count down 5, 4, 3, 2, 1. Okay, and I think we should close the poll now, Paul.
Okay, I'm just closing it now. Sorry, the poll's doing the countdown. And if it'll be with you in 5 seconds. Okay. And you should now see the results in the top right. And as you can see, we've got a good range of scores in the responses here. Very few people at the extreme end, sort of 1 or a 10, but we've got quite a few people who feel quite confident in it at a 9. It's the highest percentage with 21%.
Okay, I think actually some of our panelists are being very modest by scoring themselves as a 9 and not a 10. So, so let's see how those scores change, by the end of the session. So, let's meet our panelists. And what I'm going to ask each panelist to do is to introduce themselves and just to tell us, just maybe 30 seconds or a minute about what you've been doing with regards to your MCP experience so far. So I'm going to be democratic and I'm going to take this from the bottom up. So I'm going to start with Tim and ask him to introduce himself, and then we'll take it from there. So Tim, can you hear me? Hi Tim, can you hear me?
Yeah, hi, Tim Hallsbury.
Hi. Yeah, lovely. So Tim, you'd like to introduce yourself?
I'm Clinical Executive for Primary Care at WCCG, and I'm very much involved in the development of primary care so that they can become a suitable group to enter the MCP project in an effective way and take their part in being the central sort of key elements of how we develop a community development project.
Brilliant. And I can see that Paul's there with you. So Paul, would you like to say hello at the same time?
Hi there. Yeah, so I'm Paul Moback. I'm the Chief Exec Officer for WCCG, and really at the moment the main agenda that I'm working on is all the details around the outcome objectives for MCP, scope of services, how we're designing the new contracts on the back of the MCP framework so that we can actually properly commission the MCP as a legal entity, in its own right.
Yeah, fantastic. And it's great to have you on our panel. Moving upwards, my next speaker is Andrew Weatherburn. Can you hear me, Andrew?
Yeah, I can hear you.
Yeah, fantastic. So would you like to introduce yourself and just tell us what you're up to, MCP-wise?
So I'm Andrew Weber. I'm a community geriatrician now, was but predominantly hospital-based up until about a year and a half ago. Still do some acute on-call, and I'm the clinical lead for our new model of care, one of our new models of care, which is called extensive care, which is based on an extensivist model across the Fylde coast, and also one of our clinical vanguard leads as well for the Fylde coast.
Yeah. Welcome, Andrew. And our next person is Shira, Dr. Chok Shira. Hi, can you hear me?
Hi, Helen. Yes, I can.
Hi, fantastic. So would you just like to tell us what you're up to, MCP-wise?
Yeah, I'm a GP in Tower Hamlets and clinical associate with the New Care Model team, so helping the vanguards deliver what they want to achieve, and Director of Primary Care at Berks Hill. So bringing a primary care perspective to an acute trust and listening to our primary care partners and building those important relationships across acute and primary care.
Fantastic, and welcome. And our next panelist is Simon Butler. So Simon, would you like to say hello and tell us about what you're doing MCP-wise?
Hi. Yeah, my name's Simon Butler. I'm a GP at the Modality Partnership in Birmingham. Hello. We are part of the Connected Care Partnership covering West Birmingham. General practice redesign, creating a new model of care.
Yeah, great. Next person actually in my list is Louise Watson, but I'm going to make Louise go last because I'm going to actually get her to talk to the next slide. So our final panelist here is Christine Morgan, who is an expert by experience. So Christine, tell us what you're doing in support of your local MCP care model.
Well, hi everybody. Yes, I'm Christine Morgan, and I'm working with the Stockport Together Vanguard, and I started working with them on their citizens panel, which is a range of people with different interests, from members of the public, some are patients, some are carers, all coming together to really get in at the strategic end and hopefully help to produce the parts of the Vanguard and as things go on and evolve. So that panel is there's a reference group, and different members are also getting involved with some of the more detailed work from the neighbourhood hubs, the healthy communities group, the acute care side of it. So there are opportunities for people if they've got the time to get more involved and then bring back that kind of a bit more intelligence and so that they can see that they really are part of this. So I think Stockport are being very trusting and really trying to work directly in a co-production way with their public.
Yeah, that's wonderful to hear that, Christine, and it's fantastic to have you on the panel. So our last panellist is Louise Watson, who is, as we can see on the slide, the national lead for MCPs. So what I thought we ought to do is just get Louise to say something about what an MCP is. And you know, I know lots of us will have already have prior experience and will have watched the video beforehand, but we thought, you know, in order to get our discussion going, let's get Louise to tell us about that. And in the meantime, you can see just what a fantastic and eclectic, diverse group of people we have here. So can you be thinking about what questions you would like to ask our panel, and we'll see where our questions are after Louise is finished. So, Louise, can you give us kind of MCP in a nutshell?
Yes, thank you, Helen. So what you have in front of you is a very simple descriptor of the multi-specialty community provider model. And when we talk about this model, we talk about it as a population health-based model based on the GP registered list, very much built from the locality, from the neighbourhood, and built up around GP practice and the primary and community care community that are engaged with that practice. So what I wanted to do is quickly run through these different aspects from the bottom to the top in terms of the pyramid of care. The first one is around the whole population. So what we talk about here is that we have a responsibility as individuals for the whole population's health needs. And this is about supporting the population to stay well and to manage behaviours which may on occasion be unhealthy, and to promote behaviours that promote good health and that enable people to manage their own health and care needs. We talk about this, and we are developing initiatives around community engagement and community activation, which will enable the whole community to look after people that live there. And we've got panellists on the call today who will be able to talk about that in more detail. As we move up through the pyramid, we then focus on urgent care needs. And this is very much about ensuring that when people within the community have an urgent care need, that there is a very effective local network of urgent care services sitting within the community that provide that response and provide a meaningful response that is appropriate to the needs that the person is experiencing. And so within this, what we're aspiring to is an integrated provision of urgent care services such as 111, such as the minor injuries unit that may be within your location. All of those services working together and to provide this local network of urgent care as and when an individual needs it. Then moving further up, what will happen within the primary and community care community is an expansion of these services provided in the community, which will be integrated together. So you will have GP services, community services, social care, and possibly some acute services, all working together to provide an enhanced service to their population. And these will range and ensure that both physical and mental health needs are met within their community. We are exploring the use of tools to enable people to be identified for different morbidities and comorbidities. So we're talking about the use of history tools and trigger tools, which may prompt an intervention, for instance, in someone who may be at risk of a certain long-term condition. And also case finding, so identifying patients who would benefit from support, be that social care support, be that primary care support, depending on their lifestyle factors and certain care needs. And then finally, at the top of the pyramid, we talk about the extensivist model, and Andrew is on the call today. The extensivist model focuses on that very small group of patients who have high needs and high cost. where we need to support them with care plans. Potentially they are frail elderly individuals or individuals who have significant complications or long-term conditions that need to be supported in the community. And what we're planning to do within this area is not only support them with very detailed and comprehensive care plans, but wrap around a network of support for these individuals, which includes the voluntary sector and the social care sector, so that we are supporting the most vulnerable people in our communities with the best services possible. Thank you, Helen.
Yeah, thank you. I think that was a fantastic nutshell, and I think it's really great to hear description in this way. I did very badly, and I forgot one of our panelists, and that's Dr. Peter Bennett. So Peter, I'm sorry. Would you like to say hello and tell us about what you're doing MCP-wise?
Yes, hello, it's Peter Bennett here, GP in Lytham St Anne's, Lancashire. I've been involved with the Fylde Coast MCP together with Andrew Weatherburn. Initially involved in developing the clinical blueprint for an extensive care model, which is now up and running, but we're monitoring its progress on a regular basis. And now turning our thoughts more to the enhanced primary care and trying to use risk stratification and other ways of identifying how we can best deal with the second tier of the population who require enhanced support from primary care.
Thank you, Peter, and welcome everybody. So let's start the questions, and we've got a whole series of questions already. But don't forget, please put questions in the chat box, tweet them, and also what would be really fantastic is if you actually wanted to ask a question of our panel, if you can raise your virtual hand, and you can see, where you can see the virtual hand is in that row of buttons just under the participant list. So yeah, please be brave and ask a question. So let's have our first question here, and the first question is for all the panelists. In terms of your MCP journey so far, what do you think is going to make the biggest difference long term? And we'll start the other way around now. So Christine, we'll start with you, if that's okay. In terms of what you're engaged in Stockport, okay, what do you think is going to be the most significant thing long term?
I think hopefully most significantly long term is going to be the coordination of care really, and the links between. I'm thinking particularly of the communities work that's going on to look at the support that's available in the communities that involves the voluntary sector as well, so that people might get social prescribing. They might be encouraged to either join groups or be helped to go and do an activity that they really want to get out and do. So I think that's going to be important to really get all those links there. And I think particularly in the neighbourhood hub, where multidisciplinary teams are coming together, so that I think if it was me or another patient who had a problem, and if they're like me with different conditions, one thing tends to affect another. Actually, you won't just get passed around from pillar to post, but those group of people may have already had a conversation or arranged to meet you at the same time. So I mean, it's still all being worked through, but I think the more coordinated it is, so if you are moving around, you don't have to start off saying everything at the beginning, and some people saying, oh, and re-referred again. So I think sort of from a patient, carer perspective, things will be more integrated, will be more coordinated, and I think hopefully in Stockport having a big push on the communities and looking at what's already really basing on an asset-based approach. So looking at what we've already got, but maybe people just don't know about, both either clinicians and or people in the communities. So I think a lot of this work is about identifying, but making those links and finding out how actually you do those links. I suppose one last thing is, I think looking at the kind of where people do have some acute problems and getting a kind of rapid response into them so that they don't just get worse or exacerbate, and you can get that rapid response so people don't end up in hospital unnecessarily, but could be helped to be maintained in their homes. So I think all of those are really promising.
Yeah, that's kind of wonderful to hear, and I think, you know, a real picture of how the future might be. And we've got loads of questions coming in thick and fast now, which is great. So just going to ask any of our other panellists who would like to answer that question. You know, of all the things that you're doing now, what do you think is going to actually create the most impact longer term? Does somebody want to just shout in who'd like to answer that question?
Could I say something, please?
Hi, Ellen. It's Simon Butler from Connected Care in Birmingham.
Yeah.
Hello?
Hi. Hi.
Hi. No, I was going to talk about, again, in a similar vein to our last speaker, talking about the patient-centered care we're trying to deliver, but actually we're trying to push that through a new enhanced primary care model with the MDP surrounding the patient, delivering that level of coordinated care. That has to be at the heart of it. The other thing that goes alongside that is the extended access that primary care has to deliver, and the new skills bringing on board mental health, community care, and the voluntary sector as well.
Yeah, brilliant. Somebody else wants to answer that then. I think somebody else jumped in.
Andrew Wellerburn here.
Yes, hi Andrew.
For me, to be honest, coming from a hospital side in the community, it's all about a cultural change. You know, we have to really break down the traditional barriers of primary, secondary care, social care, voluntary sector, and bring them all in line together. And that's what we've been trying to do locally here, with the models of care we're trying to implement. But there's still a lot of work to be done about the sharing of patients into appropriate services and the release of our patients, that they're no longer, you know, sat in one silo, but they can be shared amongst various services who can try and coordinate and look after their care. But I really do think for the future, to keep it long-term and up and running, is that there needs to be a big cultural change from that sort of traditional way of us working across them different professional boundaries.
Okay.
Hi, could I say something about the question?
Yeah, of course.
Hi, I think the two major issues are about developing and increasing community capacity, because we need to shift the emphasis from acute to acute service. And I think culturally we're going to change the service from a reactive service to a preventative and early intervention service. And we need to take the community with us to try and get that philosophy embedded into a community across the whole age range, particularly in children, where we've got a lot of children now with long-term chronic problems who need a very different management skill set to plan their care over a long period of time. And we're going to have to alter the way that we can deliver care. And the paediatricians and ourselves don't know how to deliver care for this young complex group, because they're a new group that have never existed before. So there's going to have to be some innovative ways of working in the future for an MCP to serve its community well.
Hi Helen, can I jump in? Hello, it's Shira.
Go ahead, Shira.
Hello. For me as a GP, it's all about how we look after our workforce and how we develop our workforce to be fit for the future. Because we know that many GPs are extremely stressed, and so are many acute clinicians. So we need to look at new workforce models. We need to free up consultants and GPs and nurses and AHPs from the traditional boundaries and their job descriptions. I believe consultant job descriptions will look very different in the future. Very much in line with what some of our diabetologists are doing, Dr. Taz Chowdhury for one, who's been called a shining light of integrated working by our GP colleagues, because he comes out to the community, he teaches us about complex patients, he helps resolve issues, he gives us his mobile number, we can contact him every time there's a problem, and we work very much as a coordinated, cohesive team, rather than acute and primary care. The other thing we need to do is improve communication through technology to help our workforce talk to each other. So we asked our GPs and consultants, you know, what would make the most difference to you? And they said improve communication. So we've shared email addresses, mobile numbers. All our teams in the acute sector have NHSnet addresses for advice to GPs. And it's all about breaking down those barriers and giving people the space to meet each other and build those relationships.
Yeah. But, thank you, Shira, and I think what's coming through so strongly from these answers is the issue that yes, there's lots of opportunities to do things in different ways, structurally and technically, but so much of this comes down to relationships. So what I'm going to do now, I'm going to hand over to our chat monitors to tell us about the questions in the chat box. What I really love about what is happening here is it's almost like there's two parallel things going on. There's a verbal conversation and there's a question and answer in the chat as well. So can I ask our chat monitors, Charlotte and Dom, would you like to pick out a particular question from the chat box for our panel and tell us who asked that question?
Hi, it's Dominic here. Hi, Helen. So I think one of the first questions that Louise has been answering is in the chat, but Rosemary Stevenson asked the question, do you see MCPs working alongside integrated personal commissioning, or will MCPs evolve to absorb this? It'd be good to get your thoughts on that, Louise, if you're there.
Yes, I've answered in the chat box sort of my preliminary views, and what I've said in that is that I think very much integrated personal commissioning is part of the MCP model of care, and that because we are focusing so much on the needs of the individual, the needs of the patient, that what we're responding to here is the health and care needs of that individual. And we're hopeful that through this approach, we will actually support and increase integrated personal commissioning as a consequence of that.
Very good.
Hi, Helen, it's Charlotte here. Did you want to know?
Hi, Charlotte. Yeah, shall I just see, Charlotte, first of all, do any of our panellists want to make a comment about MCPs working alongside integrated personal commissioning? Have you got any experience of that or thinking about it? Okay.
I can say something on that if you like.
Yeah, go on then, Paul. Yeah, that'll be good.
One aspect of the kind of the personal health budget, first of all, is really about how do you engage people in setting their own objectives, which then they can engage the service with. So one of the things that, and I think that's the first step to then moving to kind of a more personalised set of budgets or personal health budgets. So one of the things that we've done in Dudley, for example, is that as part of your annual or regular long-term conditions assessment, the patients record their own personal objectives for what they want out of the management of their condition. And what they're reporting back to us is that they feel far more engaged in their consultations with their GPs and in the development or ongoing management of their condition, because they're actively contributing to the discussion in their consultation around what it is they're trying to achieve. So, this agenda doesn't necessarily have to be purely just about actually looking at this from a financial perspective. I think the first step is looking at it from actually, genuine engagement with the patient about what they're trying to achieve.
Yeah, I think wise words there. And Charlotte, have you got a question?
Yeah, so there was a question from Mina, which was about the evidence base for what it seems to be working with patients with the most complex needs. So we saw the risk pyramid earlier on from Louise in terms of needs and use of services. So what have people found in their Vanguard that has actually been showing an impact for patients at the top of that pyramid?
Okay. Yeah, great question. Should we start off with Andrew, because I know Andrew's been working with the extensivist model, which as Louise said, focuses at the top of that triangle. So let's put it up there again. So Andrew, what's your response to the question about people with the highest needs? What's working?
It really is coordinating and wrapping the care around them, to be honest. What we do is that we have a multidisciplinary team that involve, there's a mixture of there's myself as a consultant, and we've got some GP extensivists as well, advanced practitioners, care coordinators, and we have a large wellbeing support worker non-clinical workforce as well as pharmacists and other clinical staff to support the patient. And we actually lift the patient out of primary care. They still remain registered with a practice, but we look after them for the duration they're with the service and we're their first port of call. And I think some of the biggest impacts we've had are around a lot of the very simple, what we seem to be not high-polluting medical interventions, but more around things such as management of anxiety and depression, mood problems, basically coordinating their care. We've done an awful lot of work around discussions around resuscitation and palliation and advanced care planning as well for the cohort that we've been looking after. And they're the sort of very simplistic, but things that take time to do that have made quite a big difference. Plus, at the same time, helping them understand their conditions, the limitations that their conditions cause them to have, and also looking at, simple things like understanding their medicines, reviewing their medicines, linking them with social care, and linking them with various voluntary services as well through our model. So there's actually quite a lot of things, but as I say, I often say about the population we're caring for, there's a lot of things that not necessarily need a medic, but often need our well support worker to guide the patient through and to support the patient through with the support of the clinical team. What we have been finding is that those patients who have the highest risk score, that we've had some difficulty making change in and trying to activate. And as our model's developing, we've got more patients coming on board and having more numbers. Looking at some of our sort of early analysis, it is looking at as though that those patients who sit around locally are 50 to 60% risk score. So not at that very higher level, we're having the most and the greatest impact on.
Yeah, thank you, Andrew. Would anybody else like to add to that in terms of what are your experiences so far in terms of what works, regarding supporting people with the highest needs?
If I could just come in, our multidisciplinary team model, particularly with the involvement of the third sector, voluntary sector, we've shown considerable improvement in long-term care planning for patients by involving that sector. A lot of people with chronic disease have got quite low self-esteem, low motivation, and by getting them involved more in their community, often their health and their social actions improve immensely, and very little cost to that really, but makes a heck of a difference to that individual and to their community that they live in.
Yeah, wise, absolutely wise word. Yes, is that Christine, or is that Shira?
Christine.
Christine, yeah. Come on, Christine. What do you think's working for people with the highest levels of need?
I'm going to add as well another sort of technique that started in Stockport is the consultant connect. So where they have a patient who maybe does have high need, and the GP is seeing that patient and concerned about whether he needs to refer back to the specialist. They've now got a direct, it's quite simple really, a direct telephone line, so they can phone in, we've got an agreement. It started with haematology, it's going to be rolled out to other specialities. So actually a conversation while the patient is there in the consulting room between the GP and the consultant, the specialist there, back, is actually saving time for that patient, who then doesn't have to go and either go up to hospital or sometime, or wait and get a hospital appointment referred, or even maybe get it admitted. But actually it can be sorted out between the three of them, just talking together. It's back to somebody said earlier, communication between staff, but this just shows how the effect can be on patients as well.
Yeah, thank you.
Christine's absolutely right.
It's Simon here. Just to say that.
Yeah, hang on. Simon, Shira had just started, so let's have Shira and then we'll have Simon afterwards, if that's okay? Yeah, brilliant.
I agree completely with what Christine said. There are two things we've done in East London which have had a real impact on health outcomes. One is to work in networks of practices, so 4 or 5 practices incentivized jointly by the CCG to deliver improvements in health outcomes. So we're delivering some of the best care for our diabetic patients in the country, having started from the bottom quartile in the country, and by changing the culture, because we're incentivized to collaborate rather than work in silos. So we share data, we know how each other is performing, and that transparency of clinical data has really changed the way people operate. The second thing that's made a big difference, actually, in a very rapid time in our vanguard, is a virtual renal clinic for patients with renal disease. And that's quite a scary diagnosis for many patients, and it's quite a scary illness for GPs to treat as well. So our renal team thought, actually, we can do this much better. They can access EMIS, which is the GP record. GPs do referrals electronically through EMIS, so no more paper referrals being faxed back and forth. And the renal team have reduced the waiting time for a consultant opinion from 64 days to 5 days within about 6 weeks of the pilot starting. Patient education is a really important part of this project, so educating patients about renal disease, how to improve their lifestyle, how to improve their blood pressure and diet is also a key part of that project.
Brilliant. Hi, Shira.
Hello.
Hi, you hear it. So that's I think, you know, what a fantastic example. Let's hear from Simon as well. Simon, what seems to be making a difference in terms of supporting people? Yeah.
I just wanted to make one comment based on what Andrew was saying about certainly your most complex patients. The efficiencies you get through the UNDT initially are significant, but actually the role of our wellbeing coordinators in taking stuff out of the agencies, putting in simple practical suggestions with reviews at patients' home, are creating dissatisfaction amongst this group of patients. Yeah, we're having huge success there.
Yeah, wonderful. And I just think, so many great examples there. I'm just going to pause there a moment, and I'm just going to ask Catherine and Ollie, is anything happening in the Twitter sphere?
Hi, Helen. It's Catherine
Hi.
here. Yeah, there's a lot happening in terms of people quoting what's coming out and that being shared quite widely. What we've not got at the moment is a conversation going, but I think that's because a lot of this is new and interesting information for people. So there's a lot of interaction in terms of sharing what's being said and commenting on that, which is really good.
Yeah, and I think most of the chat is actually happening in the chat box. So when I've looked at the chat box, the two themes that seem to be coming up really strongly are about STPs, Sustainability and Transformation Plans, and about social care. And there's been a few comments and questions and a real conversational stream happening around that. So can we ask, how are and will MCPs work with STPs? Are MCPs going to get taken over or crushed by the STP process? And who'd like to tell us about what's happening with regard to the relationship between your MCP and your STP?
It's probably best if I give that a go.
Yeah,
okay.
great.
So, if we take our STP, which is we're part of a STP involving 4 CCGs and 5 local authorities across the Black Country. What's being recognised in our STP is very much that the new care models are the way forwards for both health and social care. And we talk within the STP about local place-based care models, of which for Dudley, the local place-based care model is the MCP. So our STP is very much recognising that actually the way in which the STP needs to progress, the details of the plan in the STP absolutely embraces the new care model, the MCP, and how that's developing. It's central really to the design of the plan.
Yeah, thank you, Paul. Anybody else like to comment from the panel?
Shall I come in, Helen?
Yes, go Christine.
Christine, just a little snippet. I won't pretend I know in great detail, but clearly Stockport is one of the Greater Manchester authorities, and obviously Greater Manchester is taking on devolution. So for Stockport, and there are other, obviously Salford has new care models as well. So I think for us it's a question of all the monies are being handled now by the devolution board, so even the new care models money is streamed through there. But in a way I sort of think of it almost in a 3D way in my head, because you've got Stockport looking at its immediate geographical area, but that is part of Greater Manchester, and we've got hospital services streamed across Greater Manchester, where we've got specialisms with neurology and with acute trauma, etc. So already across Greater Manchester, you're starting to see some of the kind of work that I think is being really made real by the new care models, by MCPs. So I think it's kind of like a microcosm that's going on in Stockport, and some of that you're seeing at large in Greater Manchester. So it's not a surprise, I think, to Greater Manchester, and I think we're quite fortunate that the STP area obviously is Greater Manchester. But it's interesting to see sort of, as I say, it's almost like 3D. You think of one and then you think of the other one above it, sort of interconnecting 3D Venn diagrams going on. But it's all with the same cause, it's all to get to the same purpose. So hopefully, you know, that will gradually come together. Definitely complex.
Yeah, but great to see the connection. And I was going to ask Louise, you know, in terms of the picture that you're seeing nationally, you know, what sense are we getting about the relationship between MCPs and STPs?
I think it's a mixed picture. Part of the aspects that we're seeing are twofold. One, that MCPs are being built and are then moving out and sharing their knowledge and sharing their learning across the STPs, so that it is being built as a model of care which the STP adopts. And then I think that's a very positive approach that we are definitely seeing emerging. And the other aspect which we're keeping an eye on currently is how primary care itself and the primary care community is engaged in the discussions about what the STP plans are developing into and what they're looking like, so that we ensure that particularly primary care clinicians and the primary care community absolutely has a voice in the development of the STP in each of the geographical areas.
Okay, thank you. So I'm going to go back, if that's okay, to Dom and Charlotte again. So do you want to kind of pick out a killer question, or a question that's, you know, getting a lot of interesting conversation going in the chat box?
Yeah, there's been quite a few questions. I don't know whether we've got time to cover them all, but
no.
Mary Hill gave a great question, which is what are the challenges with governance of MCPs? Are there any examples of what is working well? Any advice for other areas developing their own MCP model around governance structures?
Okay, great question.
Technical.
What are your governance issues panel around developing the MCPs, and are they what you expect them to be? Anybody like to comment on that?
I'll give you a start on that if you like. Governance around MCPs is quite complex, because the MCP is bringing together what in the past has been a lot of quite disconnected organisations. So it's not only GPs, but social care, community services, mental health, links into the voluntary sector, etc. So one of the challenges with the MCP is, although the opportunity is fantastic, because we're bringing all of these services and aligning them together so they can deliver better outcomes by working more effectively together. The governance to bring that together is actually quite a complex process. So it's not something that's straightforward. It needs a lot of care and attention. It needs a lot of OD, and it needs a lot of commitment from and a lot of effective relationships between the different partners to work on it together. There are a couple of particular aspects to the governance that are really important. So and those are set out in the MCP framework. So one of them is, what's the nature of the relationship? It's called the integration agreement between GP and the MCP itself. But the other aspect is, what's the nature of the governance between the different organisations that contribute to create this shared working. So the simple answer is it's not straightforward, but the opportunities you get from it are fantastic, as once you get it right.
Yeah. Thank you, Paul. Anybody else like to give any comments on your experience with regard to governance of your MCP?
I think I could add a few points on that. We've had some discussions with our legal people, with CAPSTICS, about the various rules, and I think it's frightened us all to death, really, and certainly frightened a lot of our GP colleagues. And I think the reason is because we need to approach the sort of cultural changes and trust and relationships first before we get into too much detail. I know a lot of our managers here are very keen on organisational forms, and with governance being a strong part of that. But I feel until we've got the trust, some of these discussions seem to be fairly premature and seem to be counterproductive with some of our partners, particularly some of the GPs. I see it a bit like sort of discussing how many bridesmaids you're going to have when you're on your second date, really, and I think you can frighten off a lot of people by getting too involved in the detail of governance. Once there's trust, I think the rest will flow. I don't know what other people feel about that.
It sounds pretty sensible to me, what you were just saying, Peter. Yeah, of course. Shira.
May I add something about information governance, because this is something the key part of the MCP framework. I mean, having a shared electronic framework record, which is something we've developed at Barts Health with our CCGs over the last year, has transformed patient care and patient safety. So if I could give an example. So if a patient turns up in A&E unconscious or confused, the A&E consultants can actually look at their past medical history to look at what illnesses they suffer from, what drugs they take, what they might be allergic to now, because we've managed to connect the electronic systems that the consultants use with what primary care uses. And that's completely transformed patient care and communication, because also GPs can now look up when patients' appointments are, whereas before it used to frustrate patients terribly because GPs had no idea when their appointments or surgical procedures were going to be doing. So I think we need to get over the rules and the barriers sometimes with governance and focus on what the benefits are for our patients.
Yeah. I hear that message really, really strongly. I can't believe an hour has gone so quickly. So we're really coming to the end of our time together. I'm just going to warn. I think we'll get Charlotte and Catherine to do a really quick sum up, just all reflection from the chat and the Twitter. And I've got one last question for the panelists, and because we're running out of time, what I'd like you to do is to answer this question in one breath, if that's okay. And the question is, if you were starting out again now, what one thing would you have done differently in one breath? And I'm going to start with Peter, as you were last time. So Peter, what would you do differently if you were starting out again now?
I think I would discuss more with patient groups, and particularly with consultant colleagues, we've spoken a lot in our models about activating patients and so forth. I think we need to put a lot more work into activating our workforce, and particularly activating our consultant colleagues.
Thank you. Simon, what would you do differently if you started again now? Can you hear me, Simon?
I think it's I think it's been,
Yeah.
yes, I can hear. I think it took a long time to actually agree our shared vision at the start, and what we all thought was our shared vision molded and remolded, and actually making sure at the very highest CEO level, making sure everybody is absolutely on track, everyone has the same level of commitment, and just continue refining sure that cascade throughout the different organisations from the start is key. And I think we could have done that much better. Actually, that happened.
Yeah, thank you. And Tim and Paul, as you're both together, you can go one after another. What would you have done differently?
I think we have all underestimated the amount of time and energy you need to put in achieving these projects. I think we're trying to keep the CCG's business going on our day-to-day basis and trying to do a lot of this MCP stuff on top. And although we've had some support and resources, it isn't as large a resource as we need to actually deliver this effectively. And so I think we needed, in retrospect, much more resource at the front end, really.
Did you really
Thank you.
He
has big lungs, yeah.
Yeah, he does. I think I would have started earlier, simply because I agree with the comment Pete made earlier about trust. This is a big development journey, and it takes time, and it takes trust, and it takes commitment, and it takes good relationship. And so the more time, I would like more time, really.
Yeah. Okay. Shira, what would you do differently if you were starting out now?
I think, shift the focus from collecting information to feed the beast upwards to actually collecting information that would help clinicians do their jobs better and to help them do their jobs better.
Okay, that's a very good point, and that was definitely one breath. Excellent. Andrew, what would you have done differently?
Just 3 words: engagement, engagement, engagement. To be honest, that's been the learning fact, and putting the pace, making sure that everybody understands the patient at the focus that we're trying to help here.
Yeah, fantastic, thank you. And Tim, what would you do differently?
I've already spoken.
Okay, so I know I'm getting my list wrong. And Christine, what would you have done differently?
Well, I think I'm going to echo some of what's already been said, really. I think get the patients and carer and public voice in early at the strategic level.
Yeah, fantastic. And Louise?
Final one from
in your role, actually, in your national role, what would you have done differently if you had your time again?
Oh, I haven't got. Oh goodness. Okay. In the national role, I think what I would have done differently was the development startup. We were very, very small when we started up. So the 3 of us when we first started, and it was very difficult to start such significant enterprise with such a few people, albeit that we had significant passion and enthusiasm for it. So something about having more people on the ground at the very start.
Yeah. Very good. Do you know what's interesting about all those comments is they could. They're all things that are really important, but they could almost be applied to any kind of radical change process, I think, in the health and care system. So, what I'm going to do now is, because it's time to close, I'm just going to ask Catherine to make a quick comment about Twitter, and Charlotte to make a quick comment to sum up the chat. And just while we're doing this, I mean, we're really interested to know what are your outstanding questions about MCPs. So, you know, before we end this this WebEx today, if as many of you as possible that are taking part, that are listening in, if you could actually put in the chat box what are you still curious about, and what are some of the questions that you would like to see answered around MCPs, that would really help. So, Catherine, sum up Twitter.
Twitter's been fantastic because we've been having comments from people who aren't on the session. So most of the interaction has been coming in the last half hour from people who've picked up on the conversations we're having and joined in. So I think that's really positive. The two areas that there's been most interest in is this question around collaboration with the voluntary sector. So we've been picking up a lot of people asking about that and wanting more information. And the other one is this question of building trust as a precursor to good governance. There seems to be a real appetite for learning more about that, so I'm just engaging with some people on that right now.
Yeah, thank you, Catherine. And the very last word goes to Charlotte.
Thanks, Helen. So it's quite hard to summarise a chat box because there's been a huge amount of interaction, which is fantastic. I suppose I pulled out some key themes, which is we started out with quite a lot of discussion about technology and about how that on many levels is essential for an MCP, but largely because it will enable communication, and about how communication is vital to a new model of care, and then leading from that, how communication enables relationships. And there's a great quote, relationships precede action, which I think kind of sums up what we've heard a lot this afternoon from Peter. And also discussion about social care, but also wider public services and local authority involvement in addressing the determinants of poor health through the MCP, and a suggestion that the strength of that could actually be an indicator of future success, which is an interesting to mention. And generally, I think thanks for honesty and frankness from the participants in the panel today. So that's a quick summary, Helen.
Yeah, thank you, Charlotte, so much for that. So we're coming to the end of our session together. I wanted to thank the panelists and absolutely to echo what Charlotte just said about the honesty and also the real practical wisdom. And this is the first time, like I say, that we've run a session like this, which is thought to be interactive. And I think what has really amazed me is just how much interest and wisdom and the kind of quality of the conversations that are going on. And what we'll do is we'll take the recording, we'll take the data that we've got in the chat box, and I think that will really help in terms of forward thinking. So I hope that you've all enjoyed this WebEx, and I think it's a really interesting way to end a working week. And wish everybody a great weekend, and tell everybody else to watch the recording. Okay, bye everybody.
Thank you, Helen.
Thank you. Bye.
Bye.
Thank you. Bye.
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 Thank you. Thank you very much.